Okay, dear Professor Sami, dear Chairman and colleagues, my topic is bypass surgery for Moyamoya. I come from Shanghai Huashan Hospital. Last year, we have totally more than 20,000 operations in 4 different campuses. And my personal experience now is more than 14,000 bypass cases, and still more than 6,500 patients are waiting my treatment. So actually, the bypass surgery is not only about the anatomy, but also about the hemodynamics. The first underlying logic of bypass hemodynamic is Bossuet's law. According to the Bossuet's law, delta P is the only dynamic fact that determines the direction of the blood flow and drive the blood flow. The second is Bernoulli's principle. This is the law of conservation of fluid energy, and it's a basic principle of fluid mechanics. And the delta P is the only force that drives blood flow. In this case, you can see after occlusion, the ICA, the PICA was the main feeder of the AVM nidus. So the V4 segment, actually the delta P between this segment is 0. So there's no blood flow in this V4 segment. So the classification of bypass from a hemodynamic point of view, there's 3 types. The first is through replacement, including ECIT bypass for complex aneurysms, usually combined with proximal artery occlusion. Sometimes we also use bypass for the malignant spore-based tumors, such as nasopharyngeal carcinoma, invading the ICA and require the resection of the ICA to completely resect the tumor. The second is the borrowed flow from the neighboring blood vessels, which is the ICIT bypass, normally side by side, and one proximal branch was closed. So totally blood flow after bypass decreased. The second is the flow augmentation. Normally for the Moyamoya vascular. This is full replacement. This is the highest flow bypass I ever done. You can see the bilateral ICA was totally invaded by the tumor. So we have to replace the bilateral ICA blood flow. So I used saphenous to transplant to the left side, and I did another double barrel bypass of STA to M4. So through one side, 3 bypass, we feeded the bilateral ICA. You can see the bilateral ICA totally occluded. Finally, the ENT doctors totally removed the tumor. So the patient now still alive. The second is the borrowed flow from neighboring blood vessels. This is the ICIT bypass. You can see we did the A2 to A2 side by side by anastomose, then occluded the right side A1. So after this bypass, actually the total blood flow in double A2 is decreased compared to pre-operating pre-bypass. So the augmentation is this is the augmentation in Moyamoya. So bypass Moyamoya vasculopathy, the original low pressure blood flow from ICA was not treated. A high pressure blood flow from ECA was added. So, this is a different stage of typical Moyamoya. You can see the hemodynamic change so different. This is Moyamoya syndrome, and the special Moyamoya, like Moyamoya combined with AVM. Another case of Moyamoya combined AVM. So I resected the AVM and at the same time the bypass. So in Moyamoya case, we can use 3 layers of the ECA, which is the STA or posterior auricular artery or occipital artery of the scalp. anterior deep temporal artery or posterior deep temporal artery of the temporal muscle and the middle major artery of the dura. So normally I use a combined approach to allow the maximum use of the three arteries. Skin incision, bone flap, and dura, and the bypass location would all individualize the design according to the DSA examination. So this is the ICG after the direct bypass. You can see it's a fast bilateral bidirection blood flow, which means a big delta P. In some cases of early stage of Moyamoya, we can use a keyhole approach. So in this kind of case, STA is the only donor. It's necessary to select the correct receptor site to ensure a sufficient delta P. So when delta P is within a suitable range, you can see the post-operation DSA. Actually, you can see the pressure balance point in MCA. So the blood flow from the bypass come to the M2 segment, then redistribute the blood flow around the MCA network. So the successful bypass, normally we can see a red T sign, which means a big difference of delta P. But sometimes if the delta P was too small, so in the ICG, you can see one short arm of T, which means delta P is very small. You can see almost occluded after just 1 week. When delta P is too high, you can see it can cause hemorrhage, subarachnoid hemorrhage. So we can use absorbable suture 10-0, 6-0, and 7-0 to control the blood flow in the donor artery. This is a fact after the bypass. You can see the right hemisphere, the blood flow increased so much. And we also measure the blood flow use NOVA, just Professor Fadi Shafir mentioned. You can see in the ECA branch, the blood flow was all increased, and in the main trunk of ICA and the basilar trunk, the blood flow was decreased. So the possible outcome is cure the Moyamoya. In this case, you can see the bilateral ICA was totally occluded. All the blood flow come from the ECA branches. Sometimes the STA was so the blood flow was so abundant, not only feeded the same hemisphere, but also the contralateral frontal lobe. But in most cases, there is competition between ICA and the ECA blood flow. You can see the watershed between the ECA and ICA blood flow. This is a 4D angiogram. You can see the blood flow come from STA to M2 segment. This is the Venturi effect, which means we measure the pressure of change. We can calculate the flow volume. So we measure the blood flow pressure in the Moyamoya bypass. This is a pressure detector of Abbott company. So this is the intraoperative pressure of the donor and the radial artery prior to STA's bypass. So the STA's pressure is almost the same at the radial artery. But when bypass stoma, we can measure 7 pressure parameters like this. And we also can measure the oxygen pressure at the same time. This is the hemodynamic change of Moyamoya according to the slope principle. Actually, the blood flow going through the Moyamoya network. After the Moyamoya network, the M4 segment, the pressure decreased a lot. And we measure the results through the 2 pressure gradients of MCA networks. For the first one is the pressure gradient of antelope rate, still keep the physiological direction, which means M2 segment still larger than M4 segment. but that's about 37.5% of the richer grade. The blood flow comes from the PCA or ACA. The M2 segment was the lowest pressure segment. So we made the different stage of Suzuki and the pre and the post operative. This is a pre and post operative pressure. Actually, the mean pressure gradient between the donor and recipient artery for each Suzuki stage, there's no big difference. So the mean delta P is equal to 62 centimeter water column. It's just like a little waterfall. So just like rotten small waterfall under the house. So you can see the blood flow come from STA to the M2 segment. The oxygen delta P is 13 millimeter mercury. So this is the preliminary result for visual pressure. In the donor artery, the STA pressure is quite high, close to the mean artery pressure. After the anastomosis, the blood flow was increased and the pressure gradient is reconstructed and the pressure was reduced, which is in line with the Knowles principle. In the recipient side, in line with the Sloat principle, the pressure of the distal M4 segment was significantly reduced after passing through the Moyamoya vascular network. The pressure gradient, the distal blood flow pressure, and the proximal pressure are not the same. Two pressure gradients for the MC network are proved, and a parallel bypass keeping the same direction of primary flow in the donor artery as the recipient artery gradient is reasonable. So between the donor and the recipient, the pressure difference is like a small waterfall. It's it's equal to 62 centimeter water column. After the bypass, the pressure gradient was reconstructed and formed a new ECIC watershed. So this is an inevitable phenomenon. Between the donor and recipient bloodstream, there was a significantly partial pressure difference in oxygen, average 13 millimeter mercury. So this is essential for the formation of indirect anastomosis. And we also measure the distal pressure for the side-to-side anastomosis. Actually, the pressure different delta P is same as the end-to-side anastomosis. And we also measure the tendon bypass. Actually, most of the blood flow enter the proximal stoma, forming a shunt for the distal stoma. But the proximal stoma is not blocked. The stoma pressure, the STA pressure is even lower than the distal recipient artery, and the distal end actually is useless in this case. And we found that the parallel bypass to open for one branch has little effect on the other branch's pressure. So this kind of double barrel bypass can significantly increase the blood flow. So actually, the pressure change in Moyamoya case was so complex and difficult to understand. You can see on the left side of the picture, the change of the pressure in the vein was so complicated, and we still have to learn the pressure change in the vein. The more you know, and the closer you can get the ball. Thank you. And 2 years later, we will host the MASSIN Congress in Shanghai, in Baoshan Hospital. You're welcome to visit us. Thank you.